very exciting opportunity to have a conversation about the kinds of housing and support services for all people that need supports with housing. And I think that we can get maybe to a more fundamental understanding away from the specialties and into the more general practice, especially around the issue of principles that drive many of these programs. So I am a little surprised also to be invited, as an American from the belly of the beast of capitalism, to come and give a talk to people who live in a Nordic welfare state that still believes in some way in social services and helping people. But maybe we have more in common than we know. So my talk is going to be about this Housing First program, a little bit about how it came to be and how it works. And I think that I'm going to try and emphasize some of the issues that are that we have in common with some of the program presentations we heard yesterday and some of the talks in the morning as well. Now, to make the next slide go, here we go. So we'll start with the definition for those. Housing First is a housing and services intervention that provides immediate access to housing and support services, and it's based on the philosophy of client choice. The client drives both the housing choice and the service choice. There's also a mandate that people who want to go right into housing, even if they have psychiatric or other kinds of disabilities, including addiction, there is no need for them to participate in treatment or attain a period of sobriety in order to go into the housing. Whereas most models serving people who are homeless, especially, but all people who need housing in general with disabilities, are typically required to stabilize themselves and then go into housing, which is a much harder lift than doing it the other way around. I have to say that the idea for this really came from years of street work with people who were homeless and had psychiatric disabilities, and realizing that trying to get people stabilized and sober in order to get them into housing was not working for a great number of people. And finally, stopping that effort and beginning to listen to what the clients were telling us, which is they wanted housing first. There is a dimension to this that is consistent with some of the principles and values that are both constitutionally guaranteed here, but not in the States, which is that housing is a basic human right. People who have disabilities should not have to prove that they are housing ready or worthy of housing or any other way that holds a bar for access that's higher than the simple need that they have for housing. The goals of the program are to, of course, end homelessness, but it's more ambitious than that because it's housing first, but it's not housing only. There are many support services for people after they're housed, and so the goal of the program is also to improve the person's quality of life and help them with their recovery and their community integration. Who's eligible for the program? Well, initially, the people that were eligible for this were people who were homeless and had psychiatric disabilities. Often they had co-occurring addiction and health problems. One of the things that gets lost in conversation, in clinical conversation about what is someone's diagnosis, is that we typically pick one diagnostic group. In fact, people are much more complex than that, and they have usually multiple diagnoses. Just depending on who the diagnostician is the one that comes to the forefront, or maybe who the program is serving. But people are typically much more complex than unidimensional, and that often creates problems of access to them because some programs only serve this disability group or this particular condition and not the other. And the real-life complexity of the person actually ends up being exclusionary for their ability to participate in services as they need to be. Of course, we can agree that psychiatric disability and intellectual disabilities are bona fide disabilities. We get some debate about whether addiction is a disability or whether it is somehow a more behavioral issue. And I'm not sure that we would have full agreement if we considered poverty as a disability. But I would argue that any dimension of a person's life that precludes their full participation in our social contract and restricts their access is a disability. So the group that this program initially targeted were people who were what they call chronically homeless, which means they had been on the streets for a very long time, typically a year, or they had episodic homelessness over a period of time. They were the group that had come to the attention of many community providers, criminal justice, hospital emergency rooms, detoxes, shelters, over and over again. And even though they were well known to many providers, they were not well served by any of them. So this group also was a group that was in some ways easy to develop some consensus around, because clearly they were not well served and they were in everybody's awareness. They were in the awareness of the business community, of the public. In downtown areas, they were the most visible, the most vulnerable. And so when people think about homelessness in general, they typically imagine the person that they walk past on the street, in downtown, and that is the face of homelessness. And that was the group that was targeted for this intervention. It's grown over the years to include families, for example. When I tell you a little bit more about the components of the program, I hope you'll see that it's applicable to many different populations, not just the one that it was initially intended to serve. Now, yesterday morning we heard Simone Troller, the UN Special Rapporteur, talk about the old way and the new way. And before I tell you about the Housing First program and how it's implemented, I want to just spend a moment talking about the old way and what you can't really do. Maybe there's a return button. I'm having a little trouble with the remote. Okay, thanks. So there is a way that the old system, you can't keep doing the old system and the new system at the same time. The introduction of the new system either requires a change in the old system, or else you're going to have a blurring of what is going on. And in some ways, that's happening now. There's a kind of a strong movement to do things differently. And some existing providers are simply continuing to do the same thing but calling it the new thing. But I think it's important for us to be clear about what both the assumptions and practices of the programs that we're talking about are. And so this Housing First intervention, it actually affects the clinical services sector, it affects the housing sector, and it affects in some ways the issues, more social issues of inclusion and community integration. Just in terms of the time frame of this, the changes are relatively quick. I mean, we are in a trajectory. We heard yesterday about the brief history of institutionalization, for example, in Norway, which in some ways reflects deinstitution in Europe and the United States and Canada. It's been really the last 50 years that we have really committed to having community mental health services and housing, and have moved away from institutional care. This is actually a picture of my Bellevue ward key when I'm a recovering psychologist, recovering from traditional practice. And that was the key I had, and I think that for many people that that were participating in Bellevue's psychiatric hospital and the state psychiatric hospitals, the only keys that they actually saw were the keys to the wards, or later the keys to jails. So we have come a long way, relatively short time, and we are now trying to house people that would ordinarily have been in hospitals all of their lives in the community with support. In some ways that's rather quick, given the previous 150 or 200 years, and in some ways it's slower than we can bear, because we know what to do, and it's a matter of gearing up the resources to do more of it. But I want to say, if there are times where it feels like we don't know the answers and we don't know exactly what to do, it's because we are really on the frontier of developing something that is very new and doesn't have a precedent. So we're both doing and learning and experimenting all at the same time. A number of beliefs about the old system is that people needed treatment and needed to be stable before they could be housed, that they needed supervision in the housing where they were because they couldn't manage it for themselves, and they needed us helpers to make decisions for them because we questioned their capacity to make reasonable decisions for themselves. One of the core misunderstandings, I think, is the way that the Diagnostic and Statistical Manual of the Psychiatric Association thinks about functional ability. And they look at functional ability, which is the fifth axis in a five-axis diagnosis, as a person's ability to function in social, educational, and living settings. And typically people that have a severe psychiatric diagnosis also have a very low score on functioning, because the clinician has not been able to actually observe them function in any of those settings that they're being asked to assess. In fact, it turns out when you give people an opportunity to show their abilities to function in the community, in settings that are much less restricted than institutions, their capabilities are much higher than their functionalities. So we have for a long time assumed incorrectly that people are incapable without being aware of the fact that we have put them in very restricted settings in order to assess their ability to be capable. There's a couple of other, oops, went backwards. So here's a, okay. So that's the old system, briefly, the old system that was born out of very good intentions, but set up a lot of the kinds of programs that we see today. Supervised programs, not much choice in programs, requirements for stability in order to even stay housed, linking those housing and treatment together just like they were in the hospital. And so the shift to do housing first is not just a matter of changing a few things. It's not a matter of, oh, let's do this kind of housing, let's give an apartment as opposed to a group home. It's really a fundamental shift in the way that we work. As Ruth was saying yesterday, Ruth Owen was saying that we have to change the way we think, act, and behave fundamentally in the business that we're in. We have to change our understanding, for example, about homelessness. And homelessness is not about psychopathology or addiction. It may be more about poverty. It may be that the philosophy of the clinician knowing what is best for the client is actually better served if we have the client driving the treatment and the program. That people are capable of making their decisions. Again, the UN rapporteur yesterday talked about people who are the clients have the experience. Our job is to bring to them the resources they need in order to help them realize their own goals and their own plans. The power relation is different between clinician and client. The client is in charge of the decisions, what type of service, how often to receive it, the frequency, the intensity. It's asking the clinician to get out of the driver's seat of the car and go sit in the back seat and have the client drive the car. That makes a lot of people anxious. but there's no way to change the existing system unless we can tolerate some risk and anxiety around changing the power differential as well. There's a change in service orientation. Even though it's taken a very long time to deinstitutionalize people from psychiatric settings, it's actually taking longer to deinstitutionalize the doctors and the nurses to come into the community and serve people in their homes. Community-based care is in desperate need of clinicians, and we're still stuck in an institutional setting of practice. And since we're doing something that's new and something that is untested in some ways and a lot to learn from, we're committed to an ongoing data collection, research, program evaluation, so that we can look at what we're doing, see what's effective, and change it if it's not. The Housing First program was developed out of this context that I'm describing, and it has 5 key dimensions, which I'll talk about for the next few minutes, just give you a bit of a postage stamp. The program is all about immediate access to housing, people from the streets and later hospitals, jails, going right into housing as a matter of right, and not something to be earned, and harm reduction, both in substance abuse treatment and in mental health symptoms, is an integral part of the program. You cannot really do housing first unless you are committed to a harm reduction practice, because you're going to house someone who's actively using or actively symptomatic, so you're already looking at preventing risk. So that it's an integral part of the program. The person is approached and asked for their preference in service, and it turns out most people, especially those who are homeless, want a safe, decent, affordable place to live as the first service. So housing first becomes the mandate, so you have a clinician that is looking for housing. The housing that people typically want, and this is borne out in surveys of people's preferences, is a regular place to live in the community like they had before they were homeless. A place like you and I live in that's virtually indistinguishable from any other place. People, given the choice, will typically want their own place and with the privacy and security of their own home, and will shy away from more group settings. However, more importantly than the actual choice, if somebody does want to live in a group setting, like some of the housing we saw yesterday, then the program will take them and do the best they can to help them find a place in a group setting. The choice is not ours, the choice is theirs. Most people, though, we have found, want a place of their own in the community. We don't rent more than 20% of the units in a building, for example, because we don't want to create a program. People want to live in integrated settings. They're already in an integrated setting when you keep the density low. Creating a sense of home is sort of, it's the honeymoon period. People are moving in, there's furniture provided for them. They are not moving into housing. They are moving into a place that they get to decorate and arrange and make their own. The housing has to be affordable. There's a rent supplement that's typically involved in these programs, because the government stipend isn't enough to pay for housing on the private market, rental market, and social housing units are quite rare, especially here, and it is a challenge. This whole housing availability is a huge challenge. I mean, we've heard over and over again that there's not enough affordable housing, and that's absolutely true. And I'm not really going to dwell upon that issue. Is an issue that is much larger than this conversation. What I hope to do is to describe a model for you that works and makes sense, and then if we want to take it to scale, we can have that conversation about the availability of affordable housing. I mean, I think the availability of affordable housing is a conversation that has to do with political issues. It has to do with the sort of ongoing takeover of capitalism in social services, in governments moving away, and this anguished concern about cost-benefit analysis. It's a much bigger problem than does this program work or not. It's a problem we need to address, but that's beyond the scope of this right now. The model has been replicated widely. It's in urban settings. It started out in New York City, but in Philadelphia, Vermont, all over the States now, and Canada has also adopted the model. There's lots of EU countries. There's several programs here, Sweden, France. Most of the northern European countries are working on the model. There was an 11-country FIANZA study on housing first, so that it has the components, the flexibility of renting housing quickly. You don't have to build anything, and floating services that make the program very adaptive across a wide number of settings and funding mechanisms. And it also has an adaptable size. If you want to serve 10 people in a rural setting, you need 2 case managers, and if you want to serve 100 people in an urban setting, you need 10 case managers, so that it has the adaptability of both culture, size, and geography. And the data from that is that if you're doing the program well, it works equally well wherever you do it. So that's choice. The person gets to pick their neighborhood, gets to pick their furniture, gets to pick who they live with to the extent possible. It's not absolute choice. You can't live downtown in a fancy building with an elevator. You have a choice within the restricted market of what is the affordable housing for you. The second principle has to do with the separation of housing and services, which is about the not only physical separation, the services are off-site, but also conceptually that the terms and conditions of the standard lease is what a person needs to meet in order to stay housed. They don't have to participate in treatment, and how they're doing clinically doesn't jeopardize their housing situation. Sometimes people lose their apartments, but the teams do not lose the person. This is very much a person-centered program, so that if you lose that apartment, then you have to go to the hospital, or you go to treatment, or you go to jail. The team stays with you and finds you back into your apartment or another one when you come out. So that it's very difficult people don't get lost in this kind of program. The other thing that's surprising is that housing, even though it's permanent, it's not always the same housing. People change apartments, very much like we all do. Their kids come back, they need a larger place. This man's son came back from serving in Afghanistan. He needed from a studio to a one-bedroom. The housing is movable because it's just a rental. You take the rent supplement, you rent another apartment. And of course the services are movable because they follow the person where they are. So even though it's permanent supported housing, neither of those are actually physically permanent. They're floating and can adjust to the people's needs as they go. One is where you hang your hat. You know, I mean, I know the hat is a big deal here, and so it's just like that hat. The home follows you wherever you are or wherever you need to be. The services are just exactly like that. The client is at the center of the services. The ways to provide services are very familiar to people that work in community mental health. They're either intensive case management programs or assertive case management teams or FACT teams, as they have in several countries here. And the essential part of it is that you're doing the services in the sequence that the client wants, their priorities. You can provide them directly if you have those kind of staff members on your team, or you can broker for them with other members of the community. The important thing is to keep the caseload ratios meaningfully related to the needs of the people that you're serving. If you're going to serve people with a lot of complex needs, you're going to have low caseload ratios. If you're serving people that are just moderate needs or can manage on their own, your caseload ratios can expand. And you can also have your caseload ratios within the same program changing, because not all people need all the services all the time. People do get better, and you should be able to titrate services and reduce them as people get better. The home visit is mandatory. There are two mandatory things in the program. You have to pay 30% of your income towards the rent, and you have to let the team visit you. This is housing first, but not housing only. People will come and make sure you're okay. It's a program. You don't have to participate in treatment. You don't have to take a urine test to see if you're using, but we need to know that you're okay and the place that you're living in is okay. We don't leave people alone. And hopefully, if you're doing the services correctly, and I would worry if you're not, people would be happy to see you. It's not like they have a lot of support in their life, and you should be able to, given what you're offering, be in the position of being welcomed by the person that you're visiting. And if you're not, there's a problem that has to be fixed, mostly, I think I would say, on our side. The recovery focus was talked quite a bit about yesterday. It was a very nice presentation that emphasized the role of hope and hope instilling practice. Peer relationships are key to actually helping people recover. Somebody that can say, I have been where you are and I know how you feel, is an invaluable kind of support that goes up and down the social ranks. So community integration is already a kind of a lived experience in this program. People are living integrated with others in their community. When people do well and they no longer need the services, the teams walk away, the person stays home. They don't need to move. They are already in the apartment, in their building, in their neighborhood where they are. That's how people graduate from the program. Just a couple of words about the research and effectiveness. This program's been very well studied, and it's on the SAMHSA website of evidence-based practices. We've been working with the Veterans Administration in the United States. There were 70,000 homeless veterans, and they were having a very hard time engaging them to go to the medical center, do all the pre-screening, the requirements for sobriety and treatment before housing. And the entire VA, 135 medical centers across the U.S., adopted this Housing First program, and in 2 years, they had a 35% reduction in the 70,000 veterans that they're intending to house. That's probably the largest scale program that we've been participating in. The state of Utah had a 72% reduction in chronic homelessness statewide using this Housing First approach. One of the more exciting research projects that have been involved recently is the Canadian project that was funded by the Mental Health Commission of Canada. They were interested in addressing chronic homelessness, and they spent $110 million in 5 cities across Canada: Vancouver, Winnipeg, Toronto, Montreal, and Moncton. And they did a randomized control trial, kind of an extraordinarily well-conducted both program and research study. They had 2,250 people that were randomly assigned to either Housing First or Treatment as Usual. And Treatment as Usual, was the typical treatment and housing programs. And I must say this, what we've learned in that setting, what I've observed also in settings in Europe, where there is already a well-established social service system, it's actually harder to change than if you go to places like all of Southern Europe, like you go to Greece or you go to Portugal or to some extent Italy, Ireland, where there isn't a well-established system. It's easier to introduce a new program and do something, whereas in more established system, you have to kind of nudge your way and carefully. And this was the experience also across Canada. Some of these cities had very strong already programs for the homeless, and others had nothing at all. And it was quite a different experience implementing them. Nonetheless, they were well-trained teams, and they were very, doing the model with those 5 points very consistently. Here's the 12-month data for the people that had the highest need, about 1,000 people, 950. And this is their housing retention rate. And this is consistent with other studies that we've done. So you see, it's not a subtle effect, it's a huge effect. The red line going up talks about the fact that there are no barriers to housing. Everybody gets into housing very quickly. You know, you rent the next affordable apartment and you're in. And the line across talks about the effectiveness of the home visit and the stabilization effect of the support services that people are getting. It's a very gratifying outcome, and people reported with the second goal that the quality of life improved. I have 4 points on the takeaway. Just one last point about the Canadian study, which is that the Canadian government actually read the results of the study. Now, that doesn't happen all the time. But not only did they read them, but they changed policy around homelessness. The federal government now requires every program in Canada receiving money for homelessness to spend 60% of every dollar on Housing First programs because they have documentation that works. I mean, you talk about, integration, both vertical and horizontal. Here's an example that went the other way around. A program that started from the streets on up, developed credibility through research and practice, influencing federal policy at a very high level and changing practice, from the ground up. Sometimes it goes the other way, like as it did in the VA, but this was an extraordinary example of that influence going in the other direction. The four things I would say I've learned all these years is that people with disabilities are much more capable than we ever imagined possible if we ever give them the opportunity to show it. That as a program, as a researcher, as a policy person, as a landlord, as a member of society, if we're going to really achieve full integration for people with disabilities, we have to take more risks. We have to be more flexible. We have to sign leases for people when they don't have a good credit history. We have to be more adventurous clinically and not do it the way we were trained to do it, but do it the way that the person is asking us to do it. That the program is incredibly replicable. It takes somebody, a local champion, usually that really wants to have the program in their place, to work with the resources, to bring it to bear, and then the results will speak for themselves. And finally, there's a legal advocacy piece, which for example, the Supreme Court now mandates under the Olmstead decision that all people with disabilities, just like physical disabilities, psychiatric disabilities, and other disabilities, are by law entitled to living in a place that is least restrictive and has equal access to educational, social, and employment opportunities. And if we do all this, in the end, we will indeed have a home for all. Thank you very much.